huge resource to me, and I think to a lot of the other physicians here in our area, to not only explain circulating tumor cells, circulating DNA, Garden 360, and how that fits in with solid tumor testing. But I think to take it one step further is just that Dr. Nezami really will sit down and work with you, and I think he's open to, on this call, is working with you guys on messaging, how to relay a solid message over to your physician. So I'm going to have Dr. Nezami kind of walk through the landscape first, but then I encourage you guys, if you have questions or want to reach out to him, just let him know how you, what solutions you would need to speak with a physician. So with that, I'm going to turn it over and mute my phone so we don't get such an echo with you guys, okay? So here's Dr. Nezami.
Okay, thank you very much. Is everybody there? Okay, great. Yeah, so I usually try to make my talks very efficient and try to get the most important points crossed very efficiently, trying to avoid information that you may not use in your discussions with the physicians. I understand that you're trying to educate your customers, and your physicians mainly have some problems understanding the new biology information in cancer. So when you give talks or speak on behalf of the cares, I understand that you always have to start with some sort of a basic science in cancer biology. And so I'm trying to make that summarized so that you can get the most important points crossed. I think you can start with informing and educating your oncologist and your audience about the advantages of the new technology, if it's tissue biopsy or if it's liquid biopsy, comparing those and basically giving the advantages and disadvantages of these testings, because just as Jerome said, I believe that the testings do not substitute each other. In other words, when you're using the liquid biopsy, it has its own advantages, how the whole circulating DNA science came related to the cancer, and why this test does not replace carriers and tissue biopsy, and why it's important to do all in different kind of populations. It all has to do with the basically basic science of heterogeneity that happens in the tumor. So I try, I don't know how much time I have, but I try to summarize it, and then I also try to give you some case studies, just giving you a little bit of summary of some cases that we have had in the clinic, because every patient that comes to my clinic, we test them for all these testing. So we do molecular profiling by carriers, we do a liquid biopsy for circulating tumor cells, and as you know, in the US, circulating tumor cells assays are basically EpCAM based, and it's only done by cell search in breast, prostate, and colon cancer. But what we do is that we use the technology in Germany, and all the samples from our patients go to Germany so they can characterize circulating tumor cells on all solid tumors, and also give us all those information as far as the genomic alterations on the CTC, as well as their proteomics, so you get a functional assay of these circulating tumor cells. This is a very important information, because on every patient you can actually show how the tumor is leaking these circulating tumor cells into the new vasculature around it, and the correlation between circulating tumor cells and the patient's clinical outcome and prognosis and survival has been something that has been already proved. Versus circulating DNA, we don't have enough evidence to say that if you can lower, let's say, circulating DNA, you can actually improve patient survival. For circulating tumor cells, we can do that. Also, the other difference is that circulating DNAs are not functional assays. You cannot culture them, let's say, in animal or mice. Circulating tumor cells, you can extract it from the liquid biopsy, and you can actually culture it in media and study their expression of these genomic alterations and proteomics. So there is a big difference between the application of each of these testings. in different patient population. And when it comes to the tissue biopsy, you basically have the best information that you can act upon, because there is not enough evidence, again, to correlate with what you see in circulating DNA as far as genomic alterations and what you see in the secondary sites of metastasis. So for example, when a patient comes and the tumor has already spread from the original site to the distant organs, when you do Caris analysis on both sides, you see that the original tumor has a different genetic markup, and very often you see that the second site that you do, and I strongly recommend that that should be around for your discussion for the oncologist to really advocate to do as many tissue biopsies and molecular profiling as possible, because the original tumor may have completely different signature than the distant metastatic lesion does. And what matters is that you really have to go after this evolution of cancer. When the cancer evolves during time by selective advantage or selective pressure that basically you cause by the treatments, and that's what you really have to put your efforts on, is to educate the oncologist that every treatment that they use can cause selective advantage and selective pressure to this subcolony of the cells that will change during this pressure. So you do the treatment, let's say a patient comes with the targets originally that were driving the tumor growth. When you start a targeted therapy or cytotoxic therapy, the tumor changes those drivers because you're creating that selective pressure. So what happens is that when the tumor metastasizes after treatment or during the treatment to the distant organ, now you're dealing with a completely different type of tumor as far as the signature. And that's why you need to do Caris molecular profiling on the distant metastatic lesion so you can see those differences. Now, for the circulating DNA, you're basically doing this, or circulating tumor cells, you're doing this as a snapshot. In other words, when you do the testing, you look at what's going to happen in the future. You're looking at this circulating DNA and you're hoping that your distant metastatic lesion will have similar findings as far as genetic alterations as your circulating DNA does. In other words, when you find, let's say, a c-Met positive circulating DNA, you're hoping that the distant metastatic lesion that's going to happen in the future will have that positive c-Met, or your original tumor has a driver that is c-Met positive. In other words, that is just a prediction of what's going to happen and a fingerprint of what was originally the original tumor. But the good thing about it is that that can be monitored. In other words, the circulating DNA testing, you can do the testing often, many times, and you can compare to see if your treatment, as an oncologist, if your treatment is successful changing that signature. Versus for the tissue biopsy, when you do the molecular profiling, you don't know if the treatment has been successful or not. So it's sort of a one-time deal that you do, and you decide what sort of treatments you need to use, and then you cannot monitor as you do successfully with using circulating DNA. However, as I said, the predictability of the circulating DNA as far as what you're going to deal with is much less than what you have as an actual tumor. So again, the application of these tests are different. The other challenge that happens is that not necessarily a tumor burden has to correlate with how much circulating DNA you have. And I can give you an example because there's a lot of studies that I and Rick Lyman, the Chief Medical Officer of the Gardens, we have published or co-authored many publications together and presented at the National Cancer Institute AACR presentation last in Boston. There are a lot of studies that we use to support this hypothesis that when you use circulating DNA, you can actually monitor the patient's tumor response to your treatment by correlation that exists between the tumor burden and how much circulating DNA you have. But the reality is that this is not all across the board true, because sometimes the tumor burden is a lot and you don't have any or minimal circulating DNA existing. And sometimes the tumor burden is very small and you have a lot of circulating DNA and circulating tumor cells. So what triggers the tumor to leak these circulating tumor cells and circulating DNA into the blood is the whole concept around my therapy or epigenetic therapies, basically. So we have a protocol we use in our clinic is a combination of epigenetic modifiers that changes the tumor's accessibility to the blood new vasculature around it, so it reduces the angiogenesis, but it also changes the dynamics of the epithelial mesenchymal transition, or EMT. So when you're inhibiting, let's say with an epigenetic drug or whatsoever, you inhibiting the EMT or inhibiting the vasculature around the tumor, you're not going to have circulating DNA floating around, but you may still have a large tumor burden. So the leakage and the whole science of circulating DNA, if you go back, comes back from forensic medicine or forensic science. Basically, they started to look into, okay, so if two criminals, they both hold the doorknob of a door to get in, one may have a lot of DNA as the fingerprint is there, and the other criminal may have no DNA that is leaking out. So the same concept is true for the tumor. Some tumors have a lot of some tumors have a lot of DNA that is leaking out, and some tumors don't. And that is because of the epigenetics involved with the DNA, circulating DNA itself. The same concept is true for importance of this circulating DNA in the concept of genometastasis. In other words, when this circulating DNA float, they can actually infect the distant organ cells, and they incorporate the cancer DNA into their DNA genome, and they can cause actually metastatic lesions in the distant organs just by the DNA. So not necessarily you have to have a complete circulatory tumor cell to cause metastatic lesion. This circulating DNA also can metastasize. But how do they metastasize, and what's their ability to metastasize has to do with their epigenome. And so one other thing that our therapy does is that it shuts down that circulated DNA genometastasis, so these circulated DNA cannot access to both cancer stem cells, because they are also involved with the cancer stem cells plasticity, and that's a whole different topic which I don't think I will have time to talk about. But this goes back around the circulated DNA penetration into the distant organs. So when you're looking at a functional assay like circulating tumor cells, or a DNA genomic of the tumor that you can find as a snapshot and monitor it, this is circulating DNA. The application of these tests, as I said, can be much different than the application of what you have in an actual tumor, because ultimately, if you have a tumor that is already metastasized, you already have a second site that you can do biopsy, which, as I said, I strongly recommend you do. And you can counsel your oncologist, as I said, based on the information that you can get from second site and third site, as many sites as you can. You can have an actual different protocols that you can use to treat these tumors, because as the tumor evolves, because of the concept of heterogeneity of the tumor, as the tumor evolves, you can have different subtypes or subcolonies of the cells that can grow in different organs, and you can use different treatments to destroy them. So if a patient has a breast cancer, it's already metastasized to the lungs and it already metastasized to the bones. You can have different kinds of cancers in each of these organs. When you do the circulatory DNA, it may not correlate because of what I just explained. Obviously, what you have in the tumor is more important than what you have in the circulating DNA. But sometimes you don't have access to, let's say, a brain tumor from the breast. Sometimes you don't have access to distant organ tissue itself. So you don't have any other choices but using circulating tumor cells and circulating DNA to predict and somehow use your best guess to see what's going to be in the second site. So that's why we do all this testing. When a patient comes, we do circulating tumor cells, we do circulating DNA, and we do carries before we start them on every treatment, and we retest them for the circulating tumor cell and circulating DNA after the treatment. So again, the advantage of doing these liquid biopsies is that you can retest and you can compare. And when it comes back, the reports, you'll see there's a mutation allofraction, so it tells you if the tumor has changed its driver because of your treatment, if the tumors has increased its heterogeneity or decreased. So traditionally speaking, all these targeted therapies, I'll give you an example. A patient comes with EGFR positive lung cancer. You treat the patient with the EGFR blockade. You do a circulating DNA, and it just shows circulating DNA with positive EGFR mutation. After the treatment with, let's say, erlotinib or whatever you're using as EGFR blockade, then you retest and you do a circulating DNA on the same patient. See? Now you're dealing with 10 different mutations. And that's what we see all across the board. We already know. I have published this so many times. I have published it in Cancer Science, I published it in JCO, I published it in JCT. When you do a second analysis on the circulating DNA, now you see that the tumor has increased its heterogeneity by the targeted therapy that you used. Now this heterogeneity is called induced heterogeneity. If you look at my publications, you see that. So induction of heterogeneity is something that your drugs cause. Okay? Now you know it's like playing chess. You're playing chess with a chess player partner. Obviously, there would be a reaction from the tumors to any sort of action that you do. Now this is the tumor's reaction. Heterogeneity increases. Now the tumor is not using the EGFR positive subcolony of the cells to grow. Instead is using another driver to grow. Let's say it's a HER2 positive subpopulation that is not growing. Then you can switch the therapy to a HER2 blockade, and then you can suppress that. So by doing the circulating DNA assay serially, then you can find out what therapy would be most effective at each point of time. However, if you have a second site that is already there, the lung cancer has already metastasized to the brain and whatnot, and you have access that you can do biopsy, then obviously it is more superior to use molecular profiling on the actual tumor by carriers rather than relying your information on the circulating DNA. But so the time of these testings and what do they mean on each patient is different. Because as I said, circulating DNA or circulating tumor cells can tell you what's going to happen in the next 3 months when you do a scan. I have patients who are in complete remission, and obviously they're not going to get any treatment, which is absolutely wrong, because we already know that progression-free survival of many of our patients do not translate to a better overall survival. In fact, I just presented an abstract about why progression-free survival is the least of our success, because when you look at progression-free survival, everybody's happy, everybody's clapping hands that the patient completed remission or the progression-free survival improved. But because of the concept that I told you, either if it's cytotoxic therapy or targeted therapy that we use that accomplished that sort of progression-free survival, the tumor heterogeneity increases. And because the heterogeneity of the tumor increases, then when the patient comes back with a relapse or the patient comes back with progression of the disease, now you're dealing with different type of animal because it's now harder to treat. And therefore, you actually have to address this before it happens. So circulating DNA and circulating tumor cells obviously can help you to prevent that sort of a scenario. Unfortunately, the reason that we don't order them, or most of the oncologists don't order them, is because when you get the results, you don't know what to do with them. Most of the time it comes back with the targets that are not actionable. But the reality is that in my practice, I don't use the drugs that mostly are experimental and are not available. And just by looking as a clinician looking at the circulating DNA, I cannot say, okay, this patient needs this sort of targeted therapy. That's foolish. I have some of the doctors that just look at the circulating DNA and they say, oh, this is positive for this sort of mutation, so we're going to use this experimental drug, and that does not do anything for the patient. So that's a little bit of information on the whole concept of using each of these testings. I don't want to make this too complicated, so I want to see if anybody comes with any questions I can answer so I can facilitate this sort of discussion. Generally speaking, the tumors that have been in the pathology for several years, they're still accessible and we can still use that information. The problem is that, let's say if you're using a pathology that was 5 years past and now you want to profile it, I think by the time that you profile that, patient has either been treated by some sort of treatments or is already dead or is in remission. So the tumor does not wait 5 years and nothing happens to it. So either the patient is treated and is in remission, so there's no point of doing the profile, or the treatment has not been successful and patient has passed away, or the disease has progressed. And if that's the question you have, that if a patient has been, you have a profile, you have access to the tissue that you want to profile after 5 years, obviously you can get a different pathology, because as I said, the time makes the tumor evolve. So there's no point of getting a pathology from 5 years ago, because what you're dealing right now is completely different. Yeah, that's a very good question, but the reality is that most of the liver lesions are accessible and doing the biopsy is preferred. So I personally, in my practice, I send the patient to get the biopsy. The only times that I cannot really get the biopsy, which I think is your question, is if a patient has metastatic lesions in the brain. And in those situations when there is lesions in the brain and the biopsy is almost impossible, then there are actual progress being made on analysis of CSF for genomics, and some laboratories are working on that. But if you don't have anything from the brain and you just have, let's say, a lung or a breast that is old, I still do the old one. But I don't rely my treatments as much on the old one. I rely my information as far as what treatments I'm going to use based on all the information. So most of what I will decide, it has to do with what sort of treatments patients had received. So you have to put two things together. What was the original tumor look like? What treatments has the patient exhausted? And then what sort of circulating DNA you have. Because if you look at all these three, then you can sort of get an idea of what you're dealing with. Because as I said, let's say if the first original tumor that you got from the breast was HER2 positive, right? And the patient has already exhausted HER2 treatments. Well, the chances are that taking that information that the patient was HER2 positive and it's been already failed HER2 treatment is not going to help you. Because what you have in the brain, even if it's HER2 positive, is not going to respond to the HER2 treatments. But having those information helps you, because the same patient that I told you, if she has not received HER2 treatment and the original pathology becomes positive, and you don't have any access to the brain, even if the circulating DNA becomes HER2 negative, I will still treat the patient for HER2 therapy. So you have to put all these together. You have to have the original, even if it's old. You have to have the circulating DNA, and you have to try, except brain, I will do biopsies on really, really tough places that the cancer can grow. And as I said, I think that should be your ultimate goal, to get as much tissue biopsy, because that's what you're ultimately treating. So,
Hey Doc, I have a question. This is Patrick. So last week I was in a lunch. I walked in, and the medical oncologist that I was speaking to said, well, I just had the Garden 360 rep in here. He said that I can do profiling. We don't need solid tumor. We can just do this test and it's free. What would be the short answer? I know you gave us a lot of great information, but what's just the nuts and bolts, or like the really simplistic, 2 to 5 minute answer to a med-onc that is maybe new to profiling, that is thinking that blood-based assays are the same as solid tumor.
Yeah, I guess there was a lot of noise. Patrick is sitting across the table from me. So what was the question again?
So, can you walk us through? I had a new doctor.
Right.
He's new to profiling.
Right.
Okay. But the guidance rep, instead of saying working it in conjunction, will say, hey, just use this, it's free. What would you say in maybe a quick 2-minute spiel of the differences between the two and why that solid tumor is the standard?
Yeah, so as I said, Patrick, each test has its own advantages and disadvantages. So let me tell you, basically, it's the best way to teach an oncologist is to give them cases, because they are clinicians, they don't understand, difficult terminology. So you just have to make it very simple, and don't think that you guys are dealing with the oncologist that knows much more than you guys do. Because you're dealing with people who are clinicians, they're great in what they do in the clinics, but they don't have time to do research, they don't have even time to study their own literature. So be very confident when you're talking to them, and just make it very simple. Because the scientific, basic science, most of them have no idea. So you don't make it complicated as far as basic science. The talk that I gave you now was because I know that most of you guys are very intelligent and you understand the basic science. Otherwise, when I talk to the oncologists, I try to very, very much simplify this so they can understand, just like you said, clinically what this means. So I come with cases, okay? So the best cases, and I can go over them as I promised at the end of the lecture, are cases that are extremes. So you have a case, let's say, with pancreatic cancer, deadly cancer, is very large tumor, 7, 8 centimeter, 10 centimeters sitting in the pancreas. Patient has 2 months to live. This kind of terminology they understand, right? So you give them this case, and I can give you a series of these cases that you can use in your lectures, you can use in your speaks, so they can understand it. So exactly the same case, and these are all real, true cases. 10 centimeter mass in the pancreas, okay? Never been treated, and you want to use these testings. So what do you do? Okay, so as I said, in my practice, we do a tissue, so we send it for caries, and the caries comes up with this sort of targets. So you know that this tumor, let's say, does respond to Gemzar, and it's not responding to Abraxane, or it does respond to 5-FU and it doesn't respond to Gemzar. So you get some sort of guidelines, what sort of treatments should I use for this patient, right? So this is important, because if you put this patient on 5-FU regimen and she's not a candidate for 5-FU, you're missing the opportunity for Gemzar and Abraxane treatment. And vice versa, if you put the patient on Gemzar and Abraxane and she already fails to Gemzar and Abraxane in her molecular profiling, you're wasting her time, and she doesn't have time, she's gonna die. So instead of that, you have to do molecular profiling on early diagnosis before a patient is treated with any chemotherapy, when you don't have time. So you don't have time with this patient, average prognosis less than 6 months, so you better start your treatment after you do the molecular profiling on early diagnosis. So this is the best case that you can justify to that oncologist that using molecular profiling in early diagnosis is important. And you can't wait for this to grow and metastasize and then decide what sort of second or third line of treatment you're going to use. So that's number one. Number two is that this tumor has no circulatory tumor cells or no circulatory DNA. And as I said, I can give you these cases. So when we talk about tumor burden correlating with circulatory DNA, no, it doesn't, because the tumor is 10 centimeter and there's no circulatory DNA, right? So why is it important to do molecular profiling instead of circulatory DNA in this particular case? Because the tumor has minimum access to the blood vessels, and as I told you, this is my research, it's the epigenome of the circulatory DNA contributing to its leakage and its penetrance. So in this case, there's no circulatory DNA. So doing the circulatory DNA is not going to guide you, is not going to help you. So this is the best case to show that Caris is superior on this particular case than doing the gardens. Now we have a second case. It's completely the other way around. You have a tumor that's very small, 1/5 of the size, 2 centimeters, but it's very vascular, meaning that is actively producing vascular endothelial growth factor. We measure it in our clinic before we start the treatment, and it's very high. So the tumor is sending the signals, although the tumor is very small, but it's spreading very quickly. In this case, you may have 1,000 circulating tumor cells in 7.5 cc's of blood. So you see now, the biopsy may be very difficult because this tumor is very small. At the same time, you can rely on the functional assays in liquid biopsy and get a lot of information. Even you can find out what sort of chemotherapies you have to use. You see, so these two cases shows you there is no superiority of this test to over that test. It's the fact that each test means different things in different population. Did that help you, Patrick?
Yeah, it did. I'm sorry for getting echo. Maybe I can just speak to you and mute this. What about, is there data matching saying, well, what if they were to look at our solid tumor profiling and then look at the circulating tumor cells and say, hey, does this match up real quick?
Yes, so there is no actual data that has been published matching the circulating DNA or circulating tumor cell analysis and genomic alterations with the actual tissue, because of the fact that this sort of basically research should be very, very complicated. Becomes very complicated because, as I told you, one person can get the doorknob and there will be no circulating DNA, and then the DNA that leaches out, and the other person can make a lot of that. So because of that, there's no correlation actually between what you see in the circulating tumor cells or circulating DNA that's been published and the tumor. However, in our case studies, we've looked at this very, very carefully, because we really wanted to see if there is correlation and how should we approach this. And so what we found was that based on the assay, these circulating tumor cells, as I say, in the US, there's only 3 types of blood that is approved, but the one that in Germany we do, there is a strong correlation between the genomic alterations of the circulatory tumor cells and the actual tumor. But there is not a lot of correlation between what you see as far as circulatory DNA, genomic alterations, and what you see in the original tumor. Because original tumor may have a different sort of genomic alterations as you get that initially, because there's a time lapse. We're talking about time. During the time that the tumor starts to evolve, this heterogeneity of the tumor changes based on the selective advantage. And so this circulatory DNA change by time. So if you get that let's say on the same time, let's do a tissue biopsy today, and then we do a circulatory DNA tomorrow, right? Still there is not a lot of correlation, because when you do and we don't know yet why, because the circulatory DNA comes from one site or different sites of tumor. When you do the biopsy, you're doing biopsy on one side of the tumor, unless you do a diffusional geographic biopsy. You usually don't have enough tissue from all across the tumor, even in the original site, to have all the genomic alterations. So that's why sometimes you do 2 different molecular profilings and biopsies on one tumor, and you see 2 different results, because the biopsy, it all depends on, as I said, there is correlation between circulating tumor cells and the actual tumor. But there's not enough correlation between circulating DNA and the actual tumor. What is important though is that by your treatment as clinicians, when we treat the patient, the circulating DNA, as I said, drivers changes, so you not necessarily have to go after what happens in the next 6 months in the distant organ, rather you can predictively treat these patients. Did that help, Patrick?
Yes, yes.
That's right. Yeah, I concur with you. I think what you said is absolutely right. As I said, most of the whole science around circulating DNA came not for therapeutic reasons. And when they started doing the circulating DNA, I was involved with USC studies on the lung cancer patients when they operated on these tumors and they took them out resected, and then patient went to remission. So they wanted to monitor the patient's recurrence. So the idea was not to use circulating DNA on an active metastatic patient. Was not. The idea was to use circulating DNA on the time that patient is in remission to predict and prevent, basically secondary prevention of relapse. So then they started to think, okay, maybe we can use it on active patients who have metastatic disease. Well, yes, you can, but the specific information, as you said, you might be confounding, but many factors, and for you to be able to interpret them, you have to have other information. By itself, you can't. You have to have carriers or some sort of molecular profiling. You have to have other information before you can rely on what circulating DNA really information means. But originally, as I said, this was coming to the market as a preventive and predictive test for patients in remission.